All right, so in the interest of time, we'll keep moving along. I feel like each one of these panels, I could sit and throw questions at them for hours on end. Everybody seems to have the answers too. It's an interesting answer, so this is great. But next panel is the Diagnostics and Therapeutics panel, so just some brief introductions. We have Ying Zhang, who's a professor from Johns Hopkins Bloomberg School of Public Health. We have Rafal Tokarz. Is that even close? Am I good? All right, good enough. All right. A friend from across the park here, associate research scientist, infection and immunology at Columbia University. We also have Timothy Sellati, distinguished fellow and chair of the Department of Infectious Diseases, and also the Drug Discovery Division at Southern Research Infectious Disease Department. Southern Researchers, all right, get that correct. And of course, Kim Lewis, who doesn't need an introduction at this point, and Omai Garner, Assistant Clinical Professor, Associate Director of Clinical Microbiology from UCLA. So with that, I think we'll kick off the 5-minute talks here. You guys have the equipment?
Yeah. Perfect. So I'd like to thank the Cohen Foundation for inviting me out and say that this is really a dynamic conference. I go to a lot of conferences that are very kind of siloed into one area, so it'll just be research or just be education. So I really want to thank the Cohen Foundation for building this kind of bridges between interdisciplinary works that will allow us to kind of proceed, I think, much faster. So this is fantastic. So I am a clinical microbiology director, and I think that's not a really well-known piece for the field. And so what my laboratory does is it's a clinical diagnostic laboratory that does all of the infectious disease testing for the UCLA health system. And then I'm also the director of point of care testing. So all those small tests that happen within your office through the Department of Pathology, we work on that as well. We have an interdisciplinary team at UCLA, so I work with a couple of engineers. Professor Dino DiCarlo is a professor in bioengineering, and his specialty is microfluidics. And then I also work with Professor Icahn, and he's in electrical engineering, and for him, it's really about biomedical imaging, sensing, and nanophotonics, and that's kind of all of the things that you can do with a cell phone. And so the balance there is we come together as a team to create diagnostic platforms. We've found Lyme disease to be fascinating. So we're looking at flu, we're looking at a lot of other diseases, and this is definitely point of care related. So just kind of in picking apart the two-tiered testing system for Lyme disease, of course you start with an ELISA, which is a highly sensitive but not very specific test, right? So it's going to be confident to call a negative, but when it calls a positive, you're not sure whether or not that positive is true. Then you're going to back that up with a Western blot, which is highly specific, but not very sensitive. So a Western blot can't call a negative at all, but the hope is that you can pick out who's going to be truly positive from that first ELISA. This theme works out in a number of different diseases, right? So we used to use this model as the gold standard for HIV testing, right? You start out with an HIV ELISA, and then you back it up with the Western blot. The challenge in this model is that the Western blot is just not very good. It represents a large number of problems, especially to a clinical diagnostic laboratory. So I got 100 techs within my laboratory. We're doing about 1 million tests a year. And so the labor involved in running a Western blot and being able to subjectively see whether or not a line is there and determine whether or not that line is related to whatever protein you're looking for leads to a lot of what I like to call indeterminate calls. And so those indeterminate calls mean maybe the line is there, maybe the line is not there, and doesn't give a reliable piece of information for the patient. In addition, with HIV, it's actually reasonably straightforward. Even though there are a lot of identified antibodies, you only need 2 out of 3 to be positive, and then you can go ahead and call it. That system didn't work out well enough that the CDC has now decided that Western blots aren't recommended at all. In fact, in most diagnostic disease, we don't run a Western blot in my laboratory for anything because it's just not the gold standard anymore. You would imagine my surprise then when I kind of turned my attention to Lyme and found out the Western blot positivity was 2 out of 3 for IgM and 5 out of 10 for IgG. This really represents a system that is not very good for being able to diagnose reliably whether or not someone has disease, regardless of the fact of whether you're already past the acute phase, because these tests only look at antibody production. So you could balance this again versus HIV, right? The HIV 3rd generation test was an antibody test. The 4th generation test combines antigen and antibody together in one pot to be able to determine whether or not someone has disease all the way from acute through the end stage of disease. So I really think from a diagnostic perspective, this is what we're looking for in Lyme disease, and we're looking for it to be point of care, because the other challenge of the Western blot is that there are actually very few reference laboratories that even run this test. And so if you're trying to get this test done, I looked up the turnaround time for ARUP. The turnaround time for ARUP on this test is 9 days. 9 days is a very long time to receive a result whether or not you have a disease, and then functionally you have to be part of a large healthcare system to even be in the position to send something to ARUP. So I think there's a significant number of patients out there that this testing algorithm itself doesn't work at all. I've been informed I have a minute left, so I'm going to move quickly. So our goal is to develop a novel point-of-care Lyme diagnostic. Again, we're using this in a number of different platforms. We want to achieve a simple, low-cost, rapid, and then multiplex detection of starting out with Lyme-specific IgMs and IgGs. Basically, make the sensitivity and specificity of the ELISA and the Western blot come together in one pot so that you get, in a quantitative method without any washing or any of the other things involved in an ELISA, a readout of all 13 IgM and IgGs combined together in one test that we want to take around 10 to 15 minutes. Now, we have a couple of different platforms to be able to do this. We have a lateral flow spatial analysis platform. We have kind of a magnetic beads tensing platform, but all of it then lands on the cell phone. And then landing on the cell phone, we have some very sophisticated optics that we can get down to 1 picomolar in its concentration and recognition, and maybe be able to work out some of these patients that have a very, very low amount of antibody. And then functionally, our next milestone would be to be able to take the research that's within this room, and anytime there's a new antigen that's determined or a new antibody that's determined, have a flexible platform to place it on there. I'm happy at the end to answer any sort of questions about that. Thanks for your time.
All right, thanks. Okay, so what I would like to discuss is therapy opportunities, and I would like to start with something simple and perhaps unambiguous. Lyme disease begins with acute, and approximately 10% of patients go on to develop post-treatment Lyme disease syndrome. But interestingly, when you show up at the doctor's office, nobody tells you that you have a 10% probability that something very unpleasant is going to happen to you. And maybe we will not have any, remedy for that. We'll just give you some doxycycline and you'll be fine. And then a lot of people are not. So I was wondering what we first of all can do about that, because that seems to be pretty simple. I think it is probably clear that whatever is the cause of PTLDS, either the remaining pathogen in the form of a persister or a wrecked immune response or something else, irrespective of that, I would say that common sense perhaps tells us that the longer the pathogen is in the body, the higher the probability that there will be unpleasant consequences. So if you can diagnose early and hit it very strongly, you'll probably decrease that 10% maybe to more manageable, maybe like 1%. And so here I would say that treating with doxycycline is not a good idea. From the compounds that we've seen so far, the best available one is vancomycin. Vancomycin is not orally available, though. Disulfiram is. If it pans out, then I would recommend disulfiram for acute disease. But again, if we could predict who's at risk of developing PTLDS, then probably we would say that those people who are at risk should be given vancomycin and not doxycycline. Another possibility for treatment, also probably not terribly controversial, is Lyme arthritis, is when patients were not diagnosed early, went on to develop Lyme arthritis, and then have a typical chronic disease which requires 3 months or so of treatment. Why 3 months? Why not 1 week? I would say here probably persisters are responsible for that, because they are responsible in other infectious diseases of that sort that we know. And here again, hitting it hard with something that eradicates persisters or with pulse dosing would be probably the correct way to intervene. And then, of course, there is PTLDS, which follows after treatment. We do not know what that is. If it is the remaining pathogens. That is actually probably the simpler possibility that we can eradicate either by pulse dosing or by using things like disulfiram or vancomycin. But then there's a possibility that TLDS is not caused by a remaining pathogen. It's caused by something else, perhaps by a shift in the immune system. And one thing that I wanted to briefly introduce to you is a study that we're doing in collaboration with John Aukot's group, Mike Solosky, John Dudley, and some other people in my lab. And that is to look at the possibility of microbiome intervention, because in the end, we don't want to, we don't want to lose, irrespective of what is the reason that causes PTLDS. We want to find a response to that, a therapy. There have been pretty good studies now, animal studies, that show that in animals, in people and in animals with an autoimmune disease, there's a shift in the microbiome. In animal models, you can fix that shift, and that will ameliorate the autoimmune disease. So that's our plan. We're collecting samples right now from Aukot's slice cohort to analyze for shifts in the microbiome. If we see a shift, then we're pretty confident that we'll be able to fix it. Thank you.
Okay, I want to begin by thanking the organizers and especially the Cohen Foundation for this opportunity to talk a little bit about some research we're doing more recently in collaboration with Clement Sterl and Alan Steer at the Massachusetts General Hospital, really trying to bridge what we've been studying over the past several years in terms of Lyme disease, Lyme arthritis susceptibility in mouse models of infection, and trying to understand to what extent we've learned using those animal models is actually reflective of what might be occurring in at least a subset of Lyme arthritis patients, particularly individuals that are refractory to antibiotic treatment. So we're really interested in the variability in clinical presentation of Lyme disease, and we've really focused our attention on innate immune responses to Borrelia burgdorferi, and we're particularly interested, as I said, in that subset of individuals that, despite their initial immune response to the primary infection and the provision of antibiotics, go on to develop severe and debilitating symptomatology associated with infection, particularly Lyme arthritis. And in this regard, we've really taken advantage of the fact that there are two different genetic backgrounds of mice that are equally susceptible to infection with Borrelia burgdorferi, but have very different clinical, if you will, outcomes to that infection. On one end of the clinical spectrum, the C3HHEN mice are highly susceptible to disease. They develop very severe manifestations, including arthritis of the tibiotarsal joint. And on the other end of that spectrum, we have the C57BL6 or black 6 mice that are highly resistant to disease. So despite having a comparable bacterial burden in the joints, as is seen in the C3H mice, the B6 mice have very mild, if any, inflammatory response in the joint. And so we've spent the past several years focusing on the cellular machinery responsible for recognizing Borrelia lipoproteins and the initiation of that inflammatory response to Borrelia burgdorferi. And we've identified CD14 and toll-like receptor 2-1 heterodimers on the surface of cells as being a critical element of that initial inflammatory response to the bacteria. And while it's important to elicit an NF-kappa B mediated inflammatory response that results in the production of TNF, tumor necrosis factor, and interferon gamma and other pro-inflammatory cytokines that are necessary to affect killing and clearance of the bacteria, it's also important to put in place a mechanism for tempering the severity and the duration of that inflammatory response. And that's really the yin and yang relationship between the NF-kappa B signaling and the P38 MAP kinase signaling. This is essentially a negative regulatory signaling pathway that's responsible for producing SOCs, suppressors of cytokine signaling. And so under circumstances where you have very low levels of CD14 on the surface of the cell, we see an uncontrolled NF-kappa B-driven inflammatory response, and you don't have the benefit, the tempering influence of that P38 MAP kinase signaling cascade. So that's a situation where you get more TNF, arthritogenic cytokine production, than, say, anti-inflammatory cytokine production, principally IL-10 production. So coming back to the C3H mice that have very severe arthritis and the B6 mice that have very mild arthritis, we find that in general the B6 mice have a tendency to produce more anti-inflammatory cytokine IL-10 in response to Borrelia infection than the C3H mice do. Now there's both a CD14 dependent and an independent mechanism whereby this balance between pro and anti-inflammatory cytokines is regulated. We've been able to demonstrate in both mouse models of infection, bone marrow-derived monocytes from mice, and in human cells that if you regulate the amount of cyclic AMP, which influences the IL-10 promoter accessibility, you can actually increase the amount of IL-10 being produced and reciprocally decrease the amount of TNF, or arthritis inducing cytokine being produced. Similarly, if you titrate in an inhibitor of P38 MAP kinase activity, you can significantly increase TNF production and decrease IL-10 production. And so we hypothesized that patients that are antibiotic refractory, that have this arthritis, may have exceptionally high responses in their joints by virtue of the fact that they have a CD14 deficient type response to the Borrelia. And so we were able to demonstrate that a subset of Lyme arthritis patients that are refractory to treatment have a specific polymorphism in TLR1. And we find that those individuals have much lower P38 MAP kinase activity. So if we take mice that are susceptible to developing arthritis and we treat them in such a way that we can increase their cyclic AMP levels, and by doing so increase their IL-10 production, we now significantly decrease the extent of inflammation in their joints. And so we want to explore, perhaps through big data analyses, what subset of the population may be more prone to this uncontrolled inflammatory response.
Thank you. The main focus of the work at our lab at Center for Infection and Immunity is trying to identify causes of disease. When we first began working on tick-borne diseases a few years back, we did so with a hypothesis that there are still agents in ticks that have not been characterized. And we believe that these agents can cause disease on their own, can perhaps be co-transmitted and exacerbate known conditions, and can perhaps also contribute to persistent conditions such as post-treatment Lyme disease syndrome. So the main focus of our work is trying to examine the tick virome. The tick virome basically stands for all the viruses that we find in ticks. This has been an area of research which historically really has not been well studied at all. And in fact, when we first began our work, Powassan virus was the lone virus that was associated with ticks in the Northeast. So our work focuses on 3 tick species: Ixodes scapularis, the deer tick, Amblyomma americanum, the lone star tick, and Dermacenta variabilis, the dog tick. These are the 3 ticks associated with transmission of human pathogens in the Northeast. We've collected approximately 2,000, actually a little bit over 2,000 ticks now from Connecticut and from New York. We focus on Fairfield counties in Connecticut and Long Island, Suffolk County, Long Island. And we pool them and examine them by high throughput sequencing to try to identify viral sequences. So far, we've examined approximately 75% of the ticks, and we've identified 25 novel viruses. Of these, 14 were found in Ixodes scapularis. We found multiple viruses at every collection site, and in addition, we've tried to look for prevalence of some of these viruses in individual ticks by PCR. Some of these viruses were present at a very high prevalence, more than 50%, in more than 50% of the ticks, some much less so, some as rare as 1 in 50. Now, in addition to the virome work, we are performing a bacteriome work where we are examining these ticks for bacteria by 16S ribosomal RNA sequencing in order to potentially identify new bacterial species. What we would like to do in the future is examine individual ticks by metagenomics, where we can look at viruses as well as the entire microbiome, where this would consist of the bacteria, fungi, protozoa, and we would like to see how all of these agents basically exist within a single tick, and how can that potentially relate to transmission. Now, we found all these viruses. What does it mean? Are they transmissible? Do they cause disease? So as a next step, what we are doing is we're designing serologic assays for a lot of these more interesting viruses that we find, and we screen sera from patients with tick-borne diseases to see whether we can identify samples that are seropositive to any of these viruses. And in fact, for one of these, we already have identified several seropositive samples, which indicates potential transmission to people for one of these viruses. Taking our work a step further, what we are ultimately interested in doing is developing a single diagnostic test that will hopefully differentiate among all main tick-borne pathogens. Now, unlike multiplex molecular assays such as PCR, where most serological tests test for a single agent, there's a lot of cross-reactivity, et cetera. There's quite a few caveats. So for this, what we are employing is a platform, a peptide array platform, which consists of the ability to print over 3 million short overlapping peptides, which will greatly enhance specificity. And the object of this is basically just to identify agent-specific epitopes that we can use to further refine the test. We have used this platform in the past successfully to identify epitopes that distinguish antibody responses between coronaviruses, specifically MERS and SARS. More recently, a lot of you probably heard about Zika. We've looked at filoviruses and flaviviruses, and one of the main problems with serodiagnosis of Zika is it cross-reacts very often with dengue viruses. Both viruses are very similar in sequence, and most serologic tests will not differentiate amongst the two. We have identified, using this platform, the very first Zika-specific epitopes, which can then be used to design a Zika-specific serologic test. So we are using this platform. We think this platform will be ideal to examine tick-borne diseases. And we have begun putting this together and basically generating a tick peptide chip. We are using many antigens for all these agents specified in the table. For Borrelia burgdorferi, for instance, we have 69 antigens, but we try to use what's known and basically identify use known antigens as well as potential antigens, and we're also including antigens for agents that we have identified as well in our work. And one of the more interesting things about this platform is we can swap out peptides as necessary based on performance, or if new agents are discovered, we can of course include them as well.
Well, thanks. We are interested in developing a more effective treatment for persistent Lyme disease. So first, I'd like to thank Cohen Foundation for the support of the work, and also thank Mount Sinai, Joe Dudley, and team for putting this conference together. And it's nice to be here. I learned a lot. So what I'm going to talk about is to give you an update about our activity on developing this potentially more effective treatment for persistent Lyme disease. So I really want to start with this slide. because this is a very important background to the complexity of the disease. It's actually, we all know Lyme is a complex disease. So the complexity actually starts from this early disease, early stage localized disease, then to this early disseminated to late disseminated, then to PTLDS. Okay, so the heterogeneity is such that it's actually can be well expressed in this light spectrum. Okay, from early Lyme, when it's red, that means the disease is more active, and then that's when the disease is more susceptible to antibiotic treatment. That's why the current treatment with 2 to 4 week antibiotics works. It's because the 2 weeks is for early Lyme, okay? But the 4 weeks is for really the late stage Lyme. When it doesn't quite work, then you repeat it 1 or 2 more times, then that may work. But then the real problem comes in when it gets to the PTLDS stage. That's, again, itself, as alluded to earlier, is a heterogeneous group that some of which actually may respond to treatment, but others do not. So here, clearly, we need a different type of approach to the disease. So we actually were interested to develop this more effective treatment through the perspective of persisters. So as we all know, the cause for the PTLDS is not very clear, okay? Some say it's due to autoimmune, others say it's a host immune response to antigenic debris, yet another theory says it's due to co-infection. And then the last possibility is this persistent infection due to Borrelia persisters. In fact, there has been various animal studies that convincingly showed this persistence phenomenon in mice, in dogs, in monkeys, as well as more recently in vitro studies from our group, from Kim Lewis' group, as well as Monica Amber's group, showed in vitro Borrelia developed persisters as well. And these persisters are tolerant, are not killed by current Lyme antibiotics. Okay, so we actually went on to develop this screened FDA drug library and identified a range of drug candidates that are more active against such Borrelia persister forms in vitro. Okay, for example, we identified candidates like daptomycin, clofazimine, sulfur drugs, etc. But yet again, we find that the persister problem here is complicated, it's complex, because they're heterogeneous as well. Not all persisters are the same. So have the spirochetal form of the persisters, that's relatively easy to kill. Okay, but it's a round body form and the biofilm-like microcolony form that's more difficult to be eradicated. We found these forms cannot be killed by the persister drugs we identified, like daptomycin. We will still need a drug combination approach, 3 drug combinations, actually 3 drugs, daptomycin, doxycycline, cephalosporin. Okay, that's able to completely eradicate the Borrelia persisters, even the most resistant forms. But the real question is whether these will work in vivo settings. So we don't quite know that. That's the work we're actually doing right now, trying to evaluate whether these drug combinations actually work in vivo setting in a mouse model in collaboration with Monica Ambers and Amir Hotzik at UC Davis. And in addition, we've done this a drug combination screen against round body forms of Borrelia persisters and identified overlapping drug candidates like daptomycin, clofazimine. In addition, we identified new drug candidates like anti-malarial drug, artemisinin, as well as ciprofloxacin, and also sulfur drugs. So we're trying these different drug combinations. So by the way, the daptomycin is an IV antibiotic. It's not very easy to use or very expensive. So we're really interested to develop oral regimens that's able to more effectively eradicate Borrelia persister forms and then evaluate these in vitro, the combination in animal model. And then if it shows activity, then go on to human clinical studies. So in the end, I want to really wrap up with some key questions. That is whether the persisters we find in vitro are really responsible for lingering symptoms in PTLDS. and whether a drug combination approach is going to be effective at killing such forms and improve patient treatment. So I guess we don't quite know that, so that's why we need to do the research in collaboration with different colleagues. So lastly, I want to emphasize the potential importance of co-infections like Bartonella. So we're collaborating with the New Spectre and Monica Ambers potentially to work on this project to develop more effective treatment for Bartonella as well. Thank you.
So one leading question I have here is, I'm just going to get right to it. No applaud. All right, you can applaud, I guess. You got to make them work harder. Come on, guys. This is it's too easy. No. So one leading question here to kick off the discussion is, one of the major concepts of precision medicine is getting the right drug to the right patient at the right time. And again, something we see in cancer and many of the analogies we've made with specific mutations in the cancer genome, which can be paired with drugs. I think we're not quite there yet for Lyme's disease, but do we see any opportunities in the near term to personalize therapies for patients, whether it's based on their genetics, whether it's based on their microbiome composition, or other markers? So I'll put that question out there and see if there's any comments.
We're sort of thinking along those lines. I mean, this is maybe only one small part of what contributes to post-treatment Lyme disease or arthritis in particular, but it would be interesting to know what percentage of those individuals that suffer from persistent Lyme arthritis actually have this particular TLR1 polymorphism that might predispose them to having a more pro-inflammatory unregulated response to Borrelia, whether that's persistent live replicating Borrelia or round body forms or biofilm forms or just bacterial debris in sites in the joint that might continue to elicit an inflammatory response. And then we can ask the same question about, you don't necessarily need to be completely deficient for CD14 to have this inability to temper the severity or duration of your response. Maybe you're expressing lower levels than another individual, or maybe your p38 MAP kinase activity is lower than another individual. So there's probably a constellation of genetic factors that we might look at to have more of a personalized medicine approach.
Kim?
Yeah, I'd like to add to what Tim was saying. Indeed, a great opportunity is to identify risk factors for PTLDS, and it looks like at this meeting, I've heard several, apart from what you mentioned. There's this CCL19 marker from Auket's team. There's the fact that 25% of patients with acute Lyme disease are seronegative. It would be very nice to know if that is a risk factor for PTLDS. Then there is, of course, the promise of big data that can show us more specifically, if you take measurements not of one marker, but of all markers of everything, if you can predict who will and will not develop the disease. And Nicole Baumgart described as well that different mice and apparently different patients respond very differently. Immune responses are very different. So I think it would be very useful to put that together and first of all do something very simple, and that is to properly treat those at risk who have an acute disease. And if we can do better than we're doing right now with doxycycline, then we can use the same approaches to then try to see if this will also be helpful for patients with PTLDS.
I think the advantage too is the technology is finally catching up. So we now actually have the ability to gather all of this data, and I think it's also becoming cheap enough to be able to do on a large scale. So if you look at something like exome sequencing and being able to whole genome sequence for orphan disease or genetic disease, that can cost between $7,000 to $11,000. That's a lot of money on a per patient level. But as these technologies get cheaper and cheaper and more multiplex, even point of care, we have the ability to then collect this data and give that data over so that it can be looked at.
Great. So I think in the interest of time, let's open it up to the audience here if there's any questions. We can get some mics. I got a question right there in the front.
More clarification of the question. A couple of the charts talked about the bullseye rash. The bullseye rash is the least common rash and only occurs in 10 to 15% of the patients. The SmithKline-Beecham vaccine studies, 1/3 of the patients who actually developed serologic Lyme had no rash at all, and of the 2/3 that had a rash, the least common was the bullseye. So we shouldn't leave people leaving here with the impression that 80% of the people get a bullseye rash. It just doesn't happen.
I have another question. Dr. Lyndon Hugh is here right now, and he did a Xenodiagnostic study where you put a tick on a patient with post-treatment Lyme disease and also some that did not have Lyme disease at all. And in one case, there was the tick picked up the infection from the patient who had post-treatment Lyme disease. In two other cases, they picked up the disease, but the strain was the same as they had in the lab, so they ruled it inconclusive. But that showed that, that the bacteria was transmitted from a patient with post-treatment Lyme disease into a tick using Xenodiagnosis.
Is there one? I'm not sure if there's an answer, if that was the question to answer there, but
Well, the question is, doesn't that mean something to you?
That means that Lyndon should do a larger study, which I understand he is doing.
Yeah, it would be incredibly powerful to have, either Lyndon's group with a larger cohort of individuals, or even better, another laboratory be able to replicate those results. And I think that's really the gold standard that drives much of the empirical research that's done in the Lyme disease field, or in any field for that matter.
Yeah, hi. I have a question on pathogen variability itself. We heard a lot about variabilities on the host side. Different animals, different individuals, symptoms seems to really vary, very heterogeneous. But in the wild, in the patient population, the Lyme disease strain is not a single strain. We have all different kinds of genotypes, as many as probably 15 to 20 in a single population. If you look at the world, there are probably like 15, 20 species. And we're discovering new species here as well. So I want to hear some comments on that.
One of the results I showed in my talk is variability in the level of persisters among Borrelia burgdorferi, and some pretty striking. In other pathogens, we link that to the manifestation of disease, and it is conceivable that people who get a high persister form of Borrelia are probably at risk of developing PTLDS, and that is another marker that makes sense to follow.
We've actually looked at the distribution of OSP-C variants in Borrelia burgdorferi, both in the black-legged tick and also small mammals across a geographic region in upstate New York, and we see some very intriguing differences in the distribution. The strains or variants of OSP-C that are typically associated with more human invasive strains tend to be found more often in the emergent area of Lyme disease, or the leading edge of disease, which is up in the Adirondack State Park, versus in more historically endemic areas of Lyme disease, such as in Albany County. It would be very interesting to know whether or not there is a relationship between what Kim is talking about in terms of those isolates of Borrelia that are perhaps more likely to become persister or give rise to persisters, and OSP-C or other genetic compositions of the Borrelia.
Another question over here?
Hi. It was shown on the slides that the B6 background mice were more resistant, right, in terms of the infection. So there's been some studies to show that the backgrounds of the mice differ in terms of heme metabolism, and there was one study that showed that the ability of the B6 mice to control their iron overload is a bit better than other strains, and I was wondering if any of the panelists have seen disturbances in heme and iron metabolism in terms of the Lyme disease in general, but specifically in terms of Borrelia infection.
That isn't something that we've looked at, but that would be very interesting to look at. There's also the potential for connections between the microbiome of B6 mice being different from C3H mice, and that could in some way also influence the inherently higher level of cyclic AMP in a B6 background versus a C3H background. And one thing that we did do is we asked the question whether or not the C3H mice that don't produce a lot of IL-10 in response to Borrelia infection are just incompetent to do so, or are they simply not licensed to do so? And so we can take the mice or the cells from the C3H mice, provide them cell-permeable cyclic AMP, and now they produce just as much IL-10 as the B6 mice do in response to Borrelia infection.
So I think we have time for one more question, if anyone's got a burning one they've been too afraid to ask, or everybody just needs caffeine. I'll pose one here, since there's a few minutes. I think it's clear that we want to hit the pathogen early and hard to treat Lyme, but of course the drugs have unintended consequences on the host. So I think we've touched on it a bit, but are there opportunities for therapeutics, or especially combination therapies, that would at the same time increase sensitivity or ability to kill the pathogen while at the same time minimizing damage or potential unintended side effects on the host?
Yeah, I'm going to take this one. So I think it's critical to identify early. I mean, I think right now the doxycycline itself works quite well. I think it could actually benefit from a more effective antibiotic like a subtle antibiotic, like even cefuroxime, which is a more powerful antibiotic than doxycycline. That may be able to be more effective, even cure the early form of the Lyme. I think the problem is we don't have proper clinical trials, which Brian and I have been discussing this deficiency in this field. That is, there are very few clinical studies that have been done that really can tell which therapy is actually better than the other. So all are based on expert opinion, not only the IDSA guideline, but also the ILS guideline. So I think what's really needed is really science-backed proper clinical trials, evaluating different treatment regimens, both single drug as well as drug combination. I think this is really urgently needed in this field.
Great. Fantastic. Well, I'd like to thank the panelists one more time here for the contribution. So.